Therapy in recent years is the introduction of abiraterone acetate. Abiraterone acetate is an inhibitor of two enzymatic pathways, also called the CYP17 enzymes. Sorry. This is a well-known scheme of the steroid synthesis in the body, including the androgen. And the abiraterone acetate is blocking the two pathways that you see on the scheme, therefore blocking completely, thank you, the production of androgens. The rationale for developing such inhibitor is an old one, actually. We know for many years that, the LHRH agonist or antagonist that we use are blocking the production of androgen only from the testis. And even under this castrate level of androgen, there is 5 to 10% of circulating androgens from the adrenal. What is newer information is that the tumor itself retains a capability of production of androgen throughout castration, and many times the androgen receptor is amplified, and a very tiny amounts of androgen from the tumor or from the adrenal can go on and produce enough androgen for the tumor to progress. So abiraterone acetate was designed to inhibit all of these three sources of androgen. The testis, of course, are already blocked, the adrenal, and the tumor production itself. Following early phase clinical trials, abiraterone was tested in two large phase 3 clinical trials. This is on the background. You can see the landscape of advanced prostate cancer, and the two trials we're talking about, 301 and 302. The 301 was tested in symptomatic metastatic patient that received already chemotherapy, and 302 trial was included patient who never received chemotherapy, again progressed with metastatic disease, and we'll see some details on that. So the first trial, the 301, was a phase 3 randomized trial, including almost 1,200 patients. All of them progressed with metastatic castrate-resistant prostate cancer and failed 1 or 2 chemotherapy before that. They were randomized to abiraterone acetate plus prednisone versus placebo and prednisone. And the primary endpoint was overall survival, and secondary endpoints were several, but included radiographical progression-free survival and time to PSA progression. The baseline characteristics of the patient are shown here. Some of them, you can see that there were 30% that had more than one chemotherapy, so these were really advanced patients. Many of them have pain. The median score for pain was 3, but so the patient was symptomatic. What is important to see is that most of the patients had a relatively good performance status, 90% 0 or 1 ECOG score. And these are the updated results after 775 events of the overall survival. This was definitely a positive trial. You can see that the overall survival was longer in 5 months, and the chances of dying was 26 less in the abiraterone group. You can see this slide that the overall survival was was better for the abiraterone acetate for most, if not all, the subgroup analysis here, including patient with pain, significant pain, including patient with visceral metastasis at the beginning. These are the secondary endpoints: radiographic progression-free survival, where the median was longer in 2 months, again statistically significant, and time to PSA progression, again the median was longer, 2 months longer, again statistically significant. Based on these results, the conclusion of this trial was that inhibition of androgen biosynthesis and androgen receptor signaling with abiraterone improves survival, even in advanced post-chemo symptomatic disease. And this, already 3 years ago, the abiraterone acetate was approved in post-chemotherapy patient. The second trial was the 302. These were metastatic patients that never received chemotherapy but progressed on hormonal therapy. They were randomized again to abiraterone plus prednisone against placebo and prednisone. This is the prostate cancer pyramid. This trial is definitely targeting a larger group of patients. This is a group of patients that we urologists and others used to give many second-line hormonal therapy in previous years, but none of those second-line hormonal therapy, including DES, ketoconazole, other antiandrogen, never showed a overall survival benefit in a phase 3 trial. So this was again unmet need that was addressed in this trial for a larger group of patients before chemotherapy, and this was the design of the trial. The primary endpoint, these are the results. The primary endpoint were both progression-free survival and overall survival. Radiographic progression-free survival was doubled in this trial from 3 months in the placebo arm to 16 months in the abiraterone arm. The overall survival, these are the initial results, didn't reach the median because the trial was stopped on interim analysis because it was not ethical to proceed, it was too good. But it showed already a positive trend toward overall survival benefit for abiraterone. These are the updated overall survival results that showed that overall survival for abiraterone was longer by 5 months. Again, it didn't reach, it was in favor, but didn't reach statistically significance. It was in favor of the abiraterone arm. Secondary endpoint, this was also a positive trial for initiation of time to initiation of chemotherapy, for time to opiate use, and time to PSA progression. Again, this based on the results of this trial that showed for the first time a drug in this setting that prolonged survival and radiological progression-free survival. This was by the end of 2012. The abiraterone acetate was approved for pre-chemotherapy, meaning for all metastatic patients who progressed on hormonal therapy. So we are now in 2014, and we are dealing with several open issues with abiraterone. One is combination. I would like to mention an open and recruiting trial, including in Israel, that is combining abiraterone plus LHRH agonist and in hormone-naive patients. So this is taking the abiraterone further down the road, back in the for the early patients, and this trial is open and is taking patient. Another trial that is open and running is a combination of abiraterone acetate and enzalutamide. Enzalutamide is a androgen receptor inhibitor, again, that showed positive trial in post-chemo and was approved for this indication. And a combination of the two is a trial that is up and running. We're dealing in 2014 with resistance to abiraterone. This is if you look at the survival curves, and you can see that between 20 and 30% of the patient never respond to abiraterone. And this is true also in part for enzalutamide. One of the answers may be a mutation of the androgen receptor. This was a recent ASCO publication from Johns Hopkins that showed a mutation called ARV7, where the androgen receptor is mutated and is lacking the binding site. And this may explain at least 20% of resistance to abiraterone that later developed maybe to resistance to enzalutamide as well. The other issue we're dealing in 2014 is timing and sequence. For the sake of debate, one of the questions regarding timing of abiraterone is whether to put it now that it's available both pre-chemo and post-chemo, whether we use it pre or after chemo. So the argument here is since it works better, it looks based on the radiological progression-free survival, it works better pre-chemo, maybe the maximal effect will be seen in this setting. On the other side, many oncologists believe that since up to 1/3 of patients never respond to abiraterone, you may miss the opportunity to give chemotherapy, and you can leave the abiraterone later. So usually, professional organizations are not that good in dealing with such a rapidly developing area.
10 seconds.
Okay. This is the AUA meeting guideline that trying to address the issue of how to deal with all these patients. These are 5 index patients. AUA, asymptomatic, minimally symptomatic. The standard now for the AUA is abiraterone acetate. If you go to symptomatic pre-chemo, of course, chemo is the best option, and radium for bone mets only, but abiraterone is still there. If you go to symptomatic after chemo, where there's a good performance status, abiraterone is the standard, again, level A. So if you look at that, you usually go back and give that abiraterone pre-chemo. So this is, again, the AUA idea of the situation. I will finish right here.
Thank you.
So the next session is challenging, and it will be given by both Cora Sternberg and Mario Eisenberger. So the title is Targeted Systemic Approaches. Cora Sternberg.
So I'm going to start out. Thank you very much for inviting me. So we have had obviously a revolution in prostate cancer therapy. We've had approval of 5 new drugs which improve survival and also quality of life. And where docetaxel was the fulcrum since 2004 for registrative purposes, we evaluated all of these agents like abiraterone and enzalutamide after docetaxel, and then we evaluated them pre-docetaxel. But this paradigm is changing. And we know that castration-resistant prostate cancer remains driven by the androgen receptor signaling, and androgen receptor alterations are also selected during therapy. And this can occur because of overproduction of testosterone from the adrenal glands, from the tumor, from the prostate cancer tumor itself. That's how abiraterone works. Androgen receptor overexpression, and we know that up to 80% of CRPCs have elevated AR gene copy number and 30% high-level amplification of the gene. We have AR splice variants. At least 20 of these has been described. That the most important one, the ARV7, will be discussed further by Mario Eisenberger in the next talk. The AR can be mutated, and we can have cross signaling as well. And we're developing therapies in combination with PI3 kinase inhibitors on abiraterone. And there can be upregulation of AR cofactors. So if we look at the novel antiandrogenic agents, the ones that are most further along in development that have had phase 3 trials post-chemotherapy and pre-chemotherapy are abiraterone, enzalutamide and or Teranol. The others are primarily in phase 1 or 2 or just beginning phase 3. Now, enzalutamide is an AR signaling inhibitor which targets multiple steps in the AR signaling pathway. It works completely differently than abiraterone. It's 8 times as potent as bicalutamide in inhibiting binding of the androgens to the AR. It then inhibits AR nuclear translocation and inhibits AR-mediated DNA binding. Now, the AFFIRM study is very similar to what you just heard in the Cougar 301 study. Patients with metastatic castration-resistant prostate cancer who have failed 1 or 2 regimens, one of which had to be docetaxel chemotherapy, are randomized 2-to-1 to enzalutamide, which is an oral drug, no prednisone is required, versus placebo and no prednisone. And at that time, after chemotherapy, we had the abiraterone study that was ongoing, but we had nothing else really available for these patients. And what was seen was a dramatic 37% reduction in the risk of death, which at the median it was 4.8 months in those patients randomized to enzalutamide versus placebo, leading to approval of this drug. So since these drugs were so effective, we then put them in the pre-chemotherapy setting for patients who are primarily asymptomatic or minimally symptomatic. The difference between this study, the PREVAIL study, and the Cougar 302 study is that in this study, some patients with visceral disease were allowed in, and some 11% of the patients did have visceral disease. This was a study in which patients were randomized 1-to-1 to receive enzalutamide or to receive placebo. Again, an oral drug, no prednisone was required in this, and most of these patients were asymptomatic and were not on prednisone in the PREVAIL study. Now, this study was published in the New England Journal of Medicine just June 1st. It's very new, hot off the presses. And what it did was it prolonged survival by 81%. Radiologic progression-free survival was 81% improved with enzalutamide. This is the highest number we've seen thus far. And it also reduced the risk of death by 29%, even though some patients then got abiraterone after in both arms and there was crossover with other chemotherapies, because this is before chemotherapy. Enzalutamide delayed the time to chemotherapy by 17 months. These are all highly statistically significant. Now, the other androgen-lowering agent is TAX700 or Teranol, which works very similar to abiraterone, inhibiting 6-17-20 lyase. The problem with this drug is it was the third kid on the block, and it's not good to be third, especially if you're copying the same design. And the same design was copying the same patients post-chemotherapy, they did the same trial pre-chemotherapy. And this may not have been a good drug, but what happened was there were a lot of drugs available afterwards. Abiraterone came on the market, enzalutamide came on the market, cabazitaxel came on the market. So this was presented at ASCO. This is the pre-chemotherapy study with or Teranol TAX700. And you can see that this drug works. There's an improvement in radiologic progression-free survival. But when you look at overall survival, there's absolutely no difference. And there was a study presented at GU ASCO in the post-chemotherapy regimen, and there they saw that particularly in North America and in Europe, where patients had access to abiraterone and they had access to enzalutamide and cabazitaxel, in other countries they may have had an overall survival difference. So this drug is completely not going to be developed any further. So it's not good to be third. And any new drug that comes along now, like ODM or any of the other new drugs, there's going to have to do something different. They're going to have to go straight up head-to-head against enzalutamide. So where my red fulcrum before was docetaxel in the middle, I think we have a moving definition, and we're having these drugs. You can see by the statistics, especially in the United States, that more and more patients are receiving these hormonal drugs before receiving chemotherapy. Now, we know, as we just heard before, that about quarter of the patients don't respond to abiraterone. They also don't respond to enzalutamide. And Eleni Stefaniou in MD Anderson was one of the first to try to see who are the non-responders to abiraterone. So what she did was bone marrow biopsies. And she said if patients have intense AR nuclear expression, or they have a high CYP expression, these are the patients who are going to respond. If they don't have that, these are the patients who are not going to respond. So when we try to decide who are the patients to give these therapies to, This is one of the things that we can use, perhaps bone marrow biopsies, but much more elegant is what you'll hear later by Mario, is looking at CTTs and looking at splice variants and to see maybe these are the patients who should or should not receive these therapies also with enzalutamide and abiraterone. The other thing is Gleason score. We know that Gleason score, the taxanes work with high Gleason score, low Gleason score, but there was a kind of myth that with high Gleason score that enzalutamide and abiraterone wouldn't work, but that's not true, and that just as presented by Pizzazzi recently at GU ASCO, that abiraterone is active both in high and low Gleason scores, so Gleason is not likely to help in our decision making. What might be helpful is if you have a patient who's been on ADT therapy for over a year, they've responded well to ADT therapy, that may be a patient that's a good candidate for another hormonal manipulation. But if you have a patient that responded like 2-3 months or something, maybe that's a patient you should seriously think about giving chemotherapy to and not one of these new AR agents. Now there's a number of studies have been done. Basically what they show is that if you give abiraterone, and then mostly there's retrospective studies done by those of us who have participated in the main registrative studies. But if you give abiraterone and then you give enzalutamide, they don't respond as well. Or if you give enzalutamide and then you give abiraterone, they don't respond as well. And these are all the studies that were presented at GU ASCO and at ASCO, all tiny studies showing that the one you give second and the one you give third don't work as well. So we really need to work out a better way of sequencing. We know that if you give abiraterone, the testosterone goes down, the AR goes up. If you give enzalutamide, the AR goes down, testosterone goes up. There's a rationale to co-target and give both of these together. These data have been updated, and the Alliance in the United States is trying to look at the combination of enzalutamide and abiraterone versus enzalutamide. And what we're doing is a study in which we did a lead-in study called Plato. Everyone gets enzalutamide, and when they progress, they're randomized to the combination of enzalutamide and abiraterone versus abiraterone and prednisone and placebo. So as I say, there's a moving definition. Many patients are getting treated just for rising PSAs. They have CRPC without even metastatic disease. We don't know what to do with these M0 CRPC patients. And this is just one of the trials. It's called the PROSPER trial, in which patients we don't know what to do with are being randomized against enzalutamide or placebo. There's another trial with the ARN compound, which is almost an identical trial with the ARN 500 versus placebo. It's called Spartan, the primary endpoint being metastatic-free survival. These are randomized 2-to-1 in these trials. So I think we have made a lot of progress. We have unequivocal evidence that AR has continued involvement throughout the entire history of the patient's disease. We need to better understand the heterogeneity in the different prostate cancers and understand which patients may or may not benefit from these therapies. These non-toxic therapies, pre-chemotherapy, have been of extreme interest to everyone, and we need to evaluate and understand better the best sequence and perhaps in the future develop cures, because right now we are prolonging survival and not really curing anyone. And I thank you now, Toda Rabah.
Next presenter, Mario Eisenberger. Sorry, Cora, there will be no time for questions. No. And it's the same title, but a different approach.
So that's why I changed my title.
Eisenberger.
Same thing, except that I think that changing our titles in terms of targeted treatment to more precision medicine, a step towards, I think it's probably a bit more consistent with what we know now, and I just want to run this by you. I think the cancer treatment in general is actually going to be very exciting. It's been exciting over the past few years, not only in prostate cancer, but in other diseases. Our knowledge about the biology of cancer in general has increased so substantially that it provides us the opportunity to design more targeted treatment outside of the conventional cytotoxic approaches. One of them that we spent, the previous speakers spent time talking about is the androgen receptor. Prostate cancer has a addiction to the androgen receptor. Even at the castration state, there is an overexpression, an instability of the gene, and amplifications, etc., are clearly the proof, perhaps, that that targeting, continue to target the AR is an important piece. We heard about the trials with abiraterone and enzalutamide is, in my opinion, sort of a proof of principle trials. They showed that, in fact, they met the endpoint in prolonging progression-free survival and survival. But why is it that some patients who actually receive abiraterone or enzalutamide, when they progress, they cease to respond to subsequent treatment? The data that is evolving, albeit preliminary, suggests that if you use one second-line therapy, the subsequent treatment is applied upon progression is not as effective, clearly not as effective as the data that was reported in a pivotal trial. And if you look at in an average of about 3 months or so, this is the median progression-free survival when either abiraterone or enzalutamide is used after one or the other. I think one of the interesting things that are evolving is the concepts of resistance. And I think as we apply that selective pressure towards the androgen receptor, there's still a rise in PSA, and clearly the androgen receptor is still operative. Here is just an example of some of the mechanisms that are involved in resistance toward the androgen receptor. And I just want to spend some time in the last one, which is the androgen receptor splice variant expression. We have other opportunities, and some of them we're going to go through very quickly here during this presentation. But the AR is a very interesting story. John Liu in our institution a few years ago described the androgen receptor that does not have the binding domain on your right-hand side is LBD. This is where the anti-androgens will bind. This is where we're going to starve out testosterone. This is where testosterone binds. The one on your left-hand side, which is the N-terminal domain, which is also, it's a transcription factor. So it's still constitutively active. It's still able to induce tumor growth. The receptor that is called the VR7, which is probably the most common and most active receptor, lacks the ligand binding domain. And the interesting thing is, this is, again, the most important one. It's increasingly expressed in patients who are progressing after castration or after subsequent second and third line hormonal therapies. And this was presented actually at ASCO, and it was very interesting. I wanted to show this is a CTC-based assay. So in circulating tumor cells, the assay is improved, and then we're able to actually separate cells, malignant cells, and through a RT-PCR test, evaluate for the presence or absence of the AR-V7, which was described a number of years by Dr. John Liu, and this is done in his laboratory. And if you look at the prevalence of expression of AR-V7, it's expressed somewhere between 11 to 25%, and then once you treat the patients with second-line hormonal therapies, this will double approximately. So it suggests that, in fact, patients who are treated that way, that could be a correlation between expression of this receptor and progression of disease. And this is well illustrated here. On the gray shows that are patients who are AR-V7 positive, so most of these patients will actually not respond to hormonal therapy. A few of those will for very brief periods of time. And this is the enzalutamide experience. And when you look at the abiraterone experience, is also very strongly correlated, suggesting that perhaps what you see is a relationship between the expression of the splice variant and the response to therapy. I think if somebody expresses a VR7, it's unlikely to respond to hormonal therapy, and I think that to either enzalutamide or abiraterone, I think we should move on to the next modality, probably chemotherapy. The interesting thing is that the presence of a truncated receptor is a good target for new compounds today that are targeting primarily the N-terminal domain. I think next 2 or 3 years we're going to see some of these compounds entering clinical trials. Well, there's several other examples of genomic alterations in prostate cancer that offer the opportunity for new drug development. PTEN is a well-known target. We talked about the androgen receptor. The ETS transcription factors are very important. For instance, PARP inhibitors are already being evaluated in combination with hormonal therapy. Aurora kinase and MYC are important genes that are amplified in aggressive subtypes in a drug that are currently being evaluated. And these are just, I don't have time, of course, but these are just an example of the drugs that are currently in development in patients who are filling that clinical phenotype. Another drug that I wanted to say it's interesting is in phase 3 trials, cabozantinib. It's a dual inhibitor of MET and VEGF receptor 2. It's in clinical trial. The early studies in patients with metastatic castration-resistant disease showed an impressive effect on bone scans. Some of it a separate bone scan improvement, but essentially these patients have also symptomatic improvement and some reduction in their tumor volumes. And this is now currently being developed in phase 3 trials in patients with metastatic castration, symptomatic and asymptomatic disease. Immunotherapy is a targeted therapy as well. The use of monoclonal antibody-based drugs linked to various antibodies is growing very rapidly, and this is currently being, again, re-emphasized in treatment of various cancers, including prostate cancers. And as you know, we have some important targets, such as PSMA, which is a very commonly targeted compounds in these combined approaches. The interesting thing is we talked about the growing clinical evidence that immunotherapy could be of benefit, particularly in melanoma and in renal cell carcinoma. We can appreciate the downstream relationship between the modulation of some of the immune targets and very important transcription processes that go downstream and may be related to immunotherapy. This is obviously a very promising area, and particularly in renal cell carcinoma, where immunotherapy is being used in combination with receptor tyrosine kinase. This is important, perhaps, even in the case of cytotoxic chemotherapy, and it's suggested that taxane treatment may impair androgen receptor nuclear accumulation. This may be an opportunity for continuing targeting the androgen receptor in patients who are receiving chemotherapy. Finally, I think the use of small, innovative approaches in nanotechnology targeting specific areas of the host and cancer, for instance, targeting PSMA is one of the strategies used in this compound, which is a bind 1014, which is currently also being tested in chemotherapy and used in clinical trials. And it's in patients with metastatic castration resistance. So it's a very small, targeted approach in patients with metastatic castration resistance. The disappointing thing is that it actually offers an opportunity for further studies. That if you look at the 9 prior studies that were done with docetaxel in patients with castration-resistant disease, combined with various approaches, they all were negative. In your right-hand side, in the red rectangle, I outlined that the fact that in the screening process for activity, we found very little evidence to suggest that some of these compounds should have gone from phase 2 to phase 3. So we had 9 trials with an average of about 1,000 patients each being carried from phase 2 to phase 3 trials. And is it surprising that these phase 3 trials are negative? And the answer is no. I'm suggesting that maybe the knowledge that we be able to accumulate from these trials could help us moving forward with some of the newer compounds. Individualization of treatment, that is precision oncology, is a challenging approach. It certainly is absolutely necessary if you're going to carry successfully some of our new molecules in cancer treatment. We're dealing with biological heterogeneity of tumor, inter- and intra-patient heterogeneity. We're dealing with the complexities of pathways, redundancy of some of these pathways, which is important in targeted treatment. parallel development of diagnostics and therapeutics. Are we hitting the target? What's the evidence of that? Do we have an intermediate endpoint to show that we actually not only selecting the right patients, but actually treating the patients adequately? Some of the old concepts of maximum tolerated dose probably will have to change. What's the patient benefit? Does it change clinical trial practice? And does it meet regulatory requirements for drug approval? These are all complications. I just want to quickly, before I finish, give you some examples of drugs in which appear to be a right target but the wrong drug. Sorafenib, which is apparently a BRAF inhibitor, it was negative, but because it doesn't really have a good BRAF inhibition. So subsequently, the drug that has shown a substantial activity, vemurafenib, which is a much better BRAF inhibitor, actually was shown to be approved in malignant melanoma in patients that demonstrate BRAF mutation. And actually, you could see down the list some of the good examples of identifying the target adequately, having the right drug to use the target are some of the important challenges that we have to face today for clinical trials. This is going to make clinical drug development a great deal more complicated. For selection of patients, we need to have a genotypic or phenotypic characterization of patient tissue, use the right drug, assess adequate endpoints, assess whether the patient's is not just having a clinical benefit, but through a repeat biopsy, see whether the target has been reached, approached, and whether that is, in fact, a very a treatment that deserves moving forward from the phase 2 to phase 3 testing. So clinical trials are going to be more complex and certainly more costly. So I'm very optimistic. I think over the past several years we've had new drugs approved in different patients based on marked symptomatic improvement in quality of life, improvement of overall survival. The landscape for metastatic castration resistance is now very broad, very wide. From the time the patients develop one metastasis until death, we may be dealing with years now. It's important to us, it's incumbent to us to actually define what the appropriate sequence is and what the appropriate treatment is for our patients. I'm furthermore optimistic. I think you could see that if one looks at publications, looked at the number of drugs that actually are currently being tested in cancer, both from immunotherapy molecules to targeted treatments to cytotoxic to hormonal compounds, that increased enormously, logarithmically over the past few years. And in prostate cancer, we have last year 94 new compounds in development. And I think that it's quite obvious to me that it's a matter of time as we become more sophisticated in drug development that will continue to make an impact in patients' survival and quality of life. So thank you for this opportunity.
We're going to carry on. Thank you, Mario. The next speaker is Leonard Gomella on immunotherapy. Pardon me. Leonard is the Chief of Urology at Jefferson in Philadelphia.
Good afternoon, Dr. Soller, Dr. Klotz. Thanks very much. I'm going to give a very quick overview in immunotherapy for prostate cancer and put it in perspective with these other treatments. In general, I think the consensus is if you're going to use immunotherapy in the spectrum of castrate-resistant prostate cancer, it probably should be one of the earliest agents at the present time that should be considered. Well, immunotherapy has a fairly long history, goes back to before the 1900s. And it was relatively quiet until the 1960s and 1970s when we began to understand the importance of the immune system in surveillance against cancer. Throughout the 1980s, there was a lot of excitement. Agents such as BCG, IL-2, which are very urologically centric, came on very strong, but there was tremendous work done in prostate cancer, and yet there was nothing specific that came up for the management of prostate cancer. However, throughout this time, a lot of basic science work was done to finally identify the fact that you could induce a prostate cancer-specific immune response in patients who had metastatic disease by directing a specific targeting against PAP, prostatic acid phosphatase, which is expressed on over 98% of prostate cancers. And that was the basis of the development of Sipuleucel T that we'll talk more about. So when we talk about vaccines for cancer, we really talk about two general classes. We talk about preventative vaccines, and we also talk about therapeutic vaccines. We have a large number of therapeutic vaccines that are out there, things that prevent HPV infection, things that prevent hepatitis and hepatomas, are actually indirectly preventative vaccines because they interfere with the viruses that ultimately cause tumorigenesis. However, when you look at the therapeutic vaccines that we have, they really fall into the bucket of true immunotherapy. And specifically, the agents that we have, which are considered to be therapeutic vaccines, are two right now, Sipuleucel T for prostate cancer and ipilimumab or Yervoy for melanoma. So, in spite of all the work that was done having difficulty identifying prostate cancer as a target for immunotherapy, there are actually quite compelling reasons why prostate cancer is a good disease for immunotherapy. We know it has a very slow-growing course. It gives the immune system a time to potentially generate a response. Prostate cancer is immunogenic and actually can induce a specific and spontaneous autoantibodies. The proteomic and microarray analysis reveal that there are multiple specific proteins that may serve as specific tumor antigens. And we now have strong laboratory data that shows that an anti-tumor response in prostate cancer cells can occur. When we look at the broad field of prostate immunotherapy, it actually mirrors what's going on in other immunology. That is, there's active immunotherapy, passive immunotherapy, and immune checkpoint inhibitors. What we're going to spend most of our time talking about is active immunotherapy. We won't really be spending much time on passive immunotherapy, which is basically the chronic administrations of things such as monoclonal antibodies. And again, the immune checkpoint inhibitors, Dr. Eisenberger referred to a little bit. Again, they're still in development in prostate cancer and under clinical trial right now. So we're going to spend most of our next few minutes talking about what's going on with active immunotherapy in prostate cancer. So where we are today is we have one officially approved active immunotherapy in the United States, Sipuleucel T. There are a series of others that are either in stalled development or late-stage development. There's the whole cell vaccine known as GVAX. The one that really is coming on the strongest right now is known as Prosvac, which is a pox virus vector that stimulates the immune system. Again, immune checkpoint inhibitors, ipilimumab, and others are being investigated. And lastly, there's actually many others out there. There's about half a dozen different immune strategies that are being looked at right now. DNA-based vaccine, PSMA antibodies that Dr. Eisenberger alluded to. Again, these are really only now coming into very early studies. So one that got a lot of attention a few years ago was the GVAX compound, which was a whole cell vaccine comprised of PC3 and inactivated LNCAP. A lot of excitement about this particular compound. However, when it was studied in a large trial comparing it with taxane, it was actually found to be inferior to taxane-based therapy. So they've kind of gone back to the basics on GVAX. And you don't hear too much about it now, but I understand in the background there's trying to be revisited going forward. I think the one that's in the nearest term for us clinically is coming into large phase 3 trials is known as Prosvac. And basically, Prosvac relies on a pox viral vector for immune stimulation. It actually consists of different types of immune stimulators. There's something known as Prosvac V, which is a recombinant vaccinia PSA construct. There's something known as Prosvac F, which is a fowl pox which is used actually as a prime boost in order to initially stimulate the immune system. And there's something known as Prosvac V plus Tricom, which is basically an adjuvant that, again, is given as a boost to stimulate the immune system. Right now, there's a large phase 3 trial that's going on right now in non-metastatic or minimally symptomatic or non-symptomatic prostate cancer, which is castrate resistance, and it has 3 arms: the Prosvac V plus the Tricom adjuvant, the Prosvac and the Tricom alone with an adjuvant placebo, and lastly, just with the blank vectors. And this trial is under the leadership of the NCI and is currently going forward. The drug we have available to us today in the United States is Sipuleucel T, and I'm sure most of you are familiar with this product. It's the patient's autologous dendritic cells are removed by leukapheresis. They are sent to a processing laboratory. In the processing laboratory, the dendritic cells are activated and loaded with a PAP, prostatic acid phosphatase, GM-CSX combination vector that basically turns the production of the dendritic cells on into activated immune cells, and then they are specifically targeting prostatic acid phosphatase in the body. This is repeated through 3 cycles right now, runs about a month. The large registration trial, which was headed up by Phil Kantoff, known as the IMPACT trial, which stands for Immunotherapy Prostate Adenocarcinoma Treatment, was a 2-to-1 randomization of Sipuleucel T versus a control. Patients underwent the leukapheresis, but they did not receive back the activated compound, and they were followed until progression. And the IMPACT trial was positive. It showed approximately 4.1 months survival advantage using the combination therapy, again, in minimally symptomatic or asymptomatic patients with castration-resistant prostate cancer. Again, this was done pre-docetaxel. As a stimulant of the immune system, you will expect some adverse events, although none were specifically life-threatening. Most patients do get fever, chills, and fatigue. About 1% in the trials ended up being admitted for severe side effects. Overall, about 2/3 of patients will have some type of systemic effect. You can minimize this with acetaminophen and Benadryl. If you look at the survival benefit, you see it in multiple patient subgroups across the board, whether or not they had a docetaxel previously, whether they have soft tissue or bony disease. But the important thing, I think, if you are interested in using Sipuleucel T, I think one of the take-home messages comes from what has been known as the PSA quartile data from the IMPACT trial, which clearly shows that if you are going to use Sipuleucel T, it is probably more beneficial to use it at the most minimal tumor burden. If you look at this quartile data, the median overall response rate in months, if the PSA was less than 22, was about 40 months, and if the baseline PSA was greater than 130, the median overall response was only 18 months. Again, if you look at this data, looking at all of the metastatic castrate-resistant trials for the approved agents to date, you will see that the best responses in this particular forest plot are seen here with a very low PSA compared to some of the other. What's going on now? There's a lot of immunotherapy trials out there. There are some of these that have been reported in preliminary studies. The bottom line is there's a lot going on continuing with Sipuleucel T and other agents. So basically, Sipuleucel T is the only FDA-approved agent we have at the present time. It gives you approximately 4 months survival advantage. Best to use it, if you're going to use it early before the patient develops symptoms. Best with low PSA, certainly the quartile data says a PSA less than 20. It is being studied in many other settings. It's been shown that combining it with Abiraterone, that the steroids really don't have a negative impact on the immune response, and there's work being done to combine the two together. And again, more and more data is coming out there that we don't have time to get into, really showing a lot of the mechanism of action and a continuation of the immune response as the cells lyse, generating additional immune response to other intracellular compounds in the prostate. And again, other vaccines are under study, and I think the one that is really closest on the heels right now of Sipuleucel T is going to to be the Prosvac. The good thing about the Prosvac, it is just basically a subcutaneous injection. There's no leukapheresis involved, and it's going to be less complex for our patients who won't have to undergo the leukapheresis and then the infusion over a 1-month period. Thank you very much.
The next speaker is George Thalmann, who will talk about stem cells in prostate cancer.
Chairman, ladies and gentlemen, there's much controversy about the issue of stem cells, cancer stem cells, in cancer in general, and so I'm sad to say I probably don't have as much data to provide in therapeutic aspects for the prostate cancer, but I would like to show you that there is a chance and a possibility that this might be a new target. But first, we have to see what are stem cells. You know all this. The main problem is after surgical or radiotherapy, treatment in curative intent, we have the problem of micrometastases that stay dormant for some time, and then after some time they wake up and progress to progressive disease, which we can then treat with hormonal treatment, and then they become castration resistant, where we have a lot of new therapeutic options that you've certainly heard now in the previous talks, and very much is ongoing as compared to a few years ago. But one of the problems of prostate cancer is that it's highly complex. You look at this circular profile of different prostate cancers. So you have here all the genes, you have here in the inner circle genes that are alterated, you have fusions, and you have upregulated or gains of copies. So it's a highly complex issue, and it will be difficult to find something that treats all of these tumors at the same time. So that's why we start looking also at other ways of looking at the cancer. Now, there's different models of tumorigenesis, and you have a stochastic and a hierarchical model. And here you have a clonal expansion where the different clones take a hit and makes the primary tumor, and one clone of this will ultimately then be the metastatic clone that is with about 1.01% of the primary tumor. And the other model is a hierarchical, where you have a cancer stem cell, and then you have transient amplifying progenitors, and then finally terminal differentiated cells. And these stem cells are also very rare cells, but they're probably, or the concept is that they might be behind the metastases, and that these may be the ones that make up the difference and the metastatic population. So the problem is you have to look for the queen bee if you look for the stem cell. And I'm not sure if you can see it, but I'll help you. She's here. So that's what we're doing with prostate cancer and with all cancer if we look for cancer stem cells. There have been stem cell-like cells, because I think that's better than the ultimate stem cell as it is, and I'll show you that in the next few minutes for prostate cancer. The initial cells were in leukemia, but then they also were found in brain tumors, epithelial tumors of breast, colon, lung, pancreas, and prostate. And what defines a stem cell? Well, the stem cell has self-renewal potential, it has a high proliferative potential, and it's multipotential, meaning that it has the ability to differentiate into the various lineages composing a specific tissue. And other important characteristics are that they persist for life, have the capacity to enter dormancy, stay dormant for many months, weeks, whatever, and then go into cell cycle again. They are often drug and radiation resistant, and they have the capacity to undergo EMT, or stem cell plasticity, meaning that they can take a more mesenchymal phenotype and move, and then at another place become more epithelial again. The group from York, with Ann Collins and Norman Maitland, reported on a stem cell population that is CD44 positive, alpha-2 beta-1 high, and CD133 positive. Now, the other two markers, CD44 and alpha-2 beta-1, are frequently found in cancer stem or stem cell-like cells. CD133 is a rather rare event, as we have had to learn and suffered long to find out that they are rare. And On the other side, we also know that this phenotype does not necessarily correlate with cells and tumor grade in their series. We did a study where we took radical prostatectomy specimens. The pathologist gave us a piece of the tumor, and we did single-cell suspensions, and then we grew them in culture on different feeder layers to then evaluate different characteristics of stemness, being tumorigenicity by a sphere assay, self-renewal potential by serial passaging, clonogenic assay to look at proliferative potential, and then we also looked at the RNA and protein expression of different markers. And what you see is that these cells, if you take them again to single-cell suspension, you can always then grow them again, and they will form new clones and new colonies. And this you can do for a long time. The difference here is not because we didn't get all the 49 cell cultures growing that long, but because we were also looking at other things, as here you have TMPRSS2 ERG expression, but they grow if you put them in single-cell suspension. And the other point is that they grow prostaspheres. That is, they grow without adherence, and they form these prostaspheres. And if you take these and look at their gene expression, you find many of these genes that are stem cell-like genes or that are involved in stemness that are upregulated in this population. And if you look at, you can also do immunohistochemistry on these prostaspheres, and here you have alpha-2, beta-1 high, you have CD44 that we have, but we also found that they express high levels of PSCA, alpha-6, c-MET, and to some extent nestin, and here you have a negative control. And this was also done by the group by Owen Whitty, and they did a selection by CD44 and CD49, and then they did one further step and proved that they can reconstitute prostate tissue by injecting these prostaspheres under the renal capsule, and then as you can see here, you have again prostatic tissue that grows, or prostate cancer that grows in these tissues. So how does prostate cancer progress to castration resistance? Well, there's the adaptation model where you treat with androgen deprivation therapy, and then you have an androgen receptor gene amplification and increased expression, but you also have gene mutations and alterations of repressors and co-repressors or co-activators, and there's also increased intratumoral thermosteroidogenesis. But on the other side, you also have these two compartments, the luminal compartment and the basal compartment. And if you look at the stem cell, it becomes several, they have by asymmetric proliferation, and they also express a set of genes, they then become transit amplifying or progenitor cells that can still become neuroendocrine cells or can become basal cells. And the majority of the part becomes then luminal secretory cells that express CK18, cytokeratin 8, NKX3.1, the homeobox gene, and PSA. Now, if we treat them by hormonal treatment, then the majority of these cells, the secretory cells, disappear. But in a seminal work, Wang and colleagues found first in mice a so-called luminal progenitor that expresses the same phenotype that is what they call the CARNs, that is castration-resistant NKX3-1 expressing cell that also expresses CK18 and also has some androgen receptor positivity. And they found that these here at the base of these stem cells, that they had two types, and this is a more basal phenotype, probably expresses more CD133, and then you have in the glands a more luminal phenotype, which is the so-called CARN. So might it be that these cells that survive so long are a phenomenon of persistence of stem cells or stem-like cells, and might this be used as a biomarker and therapeutic target? To address this question, we looked at the BM18 model, which is a xenograph model that you can put under the capsule of a nude mouse. And then when it grows nicely. When you castrate it, it disappears. But even after several weeks, you can then give back androgens and the tumor starts to grow again. And by castration, you see that you have a loss of 93% of the tumor volume and 99% of the cancer cells. And if you give back testosterone, you have again a tumor that grows. Here you have a BRDU labeling showing these are proliferating cells in the intact tumor, and there's very few BRDU positive cells in these tumors under castration. And if you look here, these are not epithelial cells, because if you look there, the green cells that are proliferating, and they are not pancytokeratin positive. So there is a population that stays dormant and survives and then reinitiates growth. And if you look at these cells, if you do laser capture microdissection, what you find that these cells express, again, this panel of genes that are characteristic for pluripotency and stemness. And we found that in this setting, the LDH1H1 gene was highly expressed, as well was NANOG. And if we did immunohistochemistry on these cells, we find that in the castrated host, you have an accumulation of cells that survive, which are LDH1H1 positive or NANOG positive, and are now the equivalent of the human castration-resistant cartons that they found. So, are these also the cells that reinitiate tumor growth? And that is so because if you give back testosterone, you see that the cells that are proliferating are not only Ki67 positive, but also LDH1H1 positive. And due to this, you see that the numbers of LDH1H1 positive cells increase over a short period of time, but then the proliferation of more differentiated cells is ongoing. And these cells also have high proliferative and metastatic potential. If you take LDH high cells and inject them into the left ventricle, cardiac ventricle of nude mice, these cells that are high LDH1 expressors form rapidly and very aggressive metastases, as shown by our colleagues in Leiden. And is this true also in humans? Well, if you look at this TMA data that we looked at.
1 minute, please.
I'm almost ready. You see, it's expressed, it's strongly expressed in castration resistance, but also in radical prostatectomy specimens. And it differentiates between cases that are LDH1 positive. They fare less well than patients who have LDH, that have no LDH1H1 expression in human prostate cancer specimens. So spheres formation, as Castellan and colleagues have shown, may also be of prognostic value, and you can also use that in a lab on a chip where you grow these cells on a chip where you can then grow them and use them for diagnostics. That is what we are doing now. And to where we go for the outlook, where can it be of therapeutic value to target stem cells, is conventional therapy that we do now is targets more the transit amplifying or more differentiated cells, and these tumor cells survive to make a tumor relapse. If we target the tumor microenvironment, or we find a therapy to target the cancer stem cell compartment, we might be able in combination to lead to a tumor regression, eventually help and prove the patient, cure the patient, but that is evidently mainly still in many ways theoretical. So the growth of human prostate cancer seems to be driven by multiple luminal stem cell-like progenitor cells that, rather than by a single primitive stem cell with a basal phenotype, these stem cell-like progenitor cells regenerate tissue and survive as dormant at castrate levels of androgens and can be reinitiated and can reinitiate growth after androgen replacement. And androgen expression by these luminal stem cell-like progenitor cells may further justify androgen deprivation therapy, because we see that also these cells are responsive to hormones, so we think we need to keep them under a certain pressure. And these two markers may be new markers for castration resistance, and I'm sure that in some years to come we will see that we also will be able to target these cells therapeutically. Thank you for your attention.
Unfortunately, we don't have time for questions, although that was a terrific talk, George. Thank you. The next and last speaker in this session, Howard Sandler, targeted irradiation.
Thank you for the introduction. I'm going to talk briefly about radium-223 as a systemic radiotherapy for prostate cancer. These are the isotopes that have been used for the treatment of skeletal metastasis, including radium-223, which is an alpha emitter, has a relatively short half-life, and the most important feature of it, given its alpha particle nature, is the very, very short range on the order of just a few cells. Radium sits here in the periodic table in the second column, in the same column as calcium, so it behaves chemically like calcium. The radium-223 product is just radium chloride as a salt, and a soluble salt, and is injected and goes to everywhere calcium goes, but obviously in a metastatic setting it tends to go to bone. So based on the availability of this product, the developers of radium-223 designed this phase 2 randomized trial looking at radium versus placebo. Local radiotherapy was given as part of the trial because patients had symptomatic disease. They got 4 monthly treatments, and interestingly, this trial did not have overall survival as its primary endpoint. The primary endpoint was a skeletal event endpoint, and it was negative. But they observed this small overall survival advantage in a very small study. Dr. Eisenberger mentioned that many phase 2 studies, the primary endpoint was not reached, and they went on to negative phase 3 trials. Well, this one, the primary endpoint was not reached, but this interesting survival secondary endpoint was reached, and they went on to a phase 3 trial, bravely, in my opinion, based on the small phase 2, and turned into an important New England Journal of Medicine paper showing the positive results in this study that is known as ALSYMPCA. And they decided to increase the number of injections to 6 4-week injections of radium versus placebo injection. I did participate in this trial, and I'm at Cedars-Sinai, so I had a sense early on about how to use this product. These are the data. There was an overall survival advantage, as you can see on the left. Remember, these are men with metastatic, symptomatic prostate cancer, castration-resistant, and they got radium, which treats only the bone compartment, does not treat any visceral disease, and yet they saw what most people consider to be an important survival benefit of 3.6 months at the median. Time to skeletal-related event was delayed. This was kind of put together on a shoestring, and they did not have a lot of extra money for quality of life studies, which is, in retrospect, is somewhat regretful, but overall survival is an important endpoint. Time to first skeletal event is an endpoint. For those of us who do radiation therapy, it's interesting. This wasn't in the New England Journal paper, but the time to first external beam radiation therapy was delayed, although ultimately the curves kind of meet at about 18 months. One criticism of this product is, while it was extremely well tolerated and there were very few hematological problems associated with it, the drug is actually excreted in the GI tract, so there was some diarrhea that was associated, but it was postulated that the short range would lead to very few hematological toxicities, and that was true. But there was concern that chemotherapy given afterwards might find the marrow to be somewhat depleted. But in this secondary analysis performed by Oliver Sartor, looking at chemotherapy post-radium-223, whether they got placebo first or whether they had radium first, there didn't seem to be any additional hematological toxicities. So apparently chemotherapy is safe to give after radium-223. So this is from a radiation oncology textbook this table was put together before radium-223, but I think that the indications for considering systemic radiotherapy are well summarized in the table. Widespread bone metastasis that are positive on a standard bone scan, diffuse pain due to multiple lesions, because after all, if you're dealing with palliation and the patient has one painful bone met, then you don't necessarily need to do systemic radiotherapy, and focal external beam radiation therapy is a good option. Issues, future directions. So just a word of caution to the non-radiation oncologists. Alpha emitters kill with a different mechanism than beta emitters. It's independent of oxygenation state and the cell cycle. Complete understanding of potential radiation sensitization mechanisms towards alpha particles requires further studies. In other words, we use a lot of radiation chemo together, but we can't extrapolate from our traditional radiation chemo to alpha particle radiation and chemotherapy. You may not get any sensitization whatsoever. There may only be additive effects. And who is responsible for delivery in the U.S.? It's a little confusing. I think it's mostly done by nuclear medicine physicians, but in the U.S. radiation oncology training program, current trainees are expected to participate in the administration of radioimmunotherapy or other targeted radiopharmaceuticals such as radium-223. Ultimately, it would be better, in my opinion, for our patients if radiation oncologists delivered this therapy rather than nuclear medicine physicians. In summary, widely metastatic prostate cancer can be well palliated with radiotherapy, either with external beam or systemic radioisotopes. And I think it's important that radiation oncologists become more involved in the management of unsealed isotopic sources. Thanks.
Thank you very much. We're running a little behind, so we're going to have to call it quits, and we'll reconvene in about 10 minutes.